Hello and welcome to the first of our ECIP webinars, Safer, Faster, Better, Setting the Pace. This is the first of 7 webinars that will happen over the coming 6 weeks, and today's webinar is presented by a person that some of you are probably already familiar with, Stephen Duncan from the Emergency Care Intensive Support Team. Before we start, just a few simple housekeeping points. Just to let you all know that this session is being recorded and the recording will be available to view on the ECIP website as soon as possible. All attendees will be muted to avoid any background noise during the recording, and at the end of the presentation there will be an opportunity to ask questions. If you do have a question, please use the raise your hand option in the panel on the right hand side of the screen and we will unmute you to answer your question. Without further ado, I'll hand over to Stephen Duncan to take us through today's presentation. Thank you, Stephen.
Thanks, Emma. Okay, everyone, and welcome. As Emma said, I'll try and make this as interesting as possible, which is sometimes hard with webinars, but hopefully if we get through the presentation quite quickly, we can concentrate on the questions and answers and have a bit of discussion. So what we're going to go through today is essentially have a quick look at the Safer, Faster, Better document that was published by NHS England. And we will have a look and see what that is and what that isn't and how we can use it. And then we're going to do a short piece on the evidence base around what good looks like for emergency departments. So first off, we will have a look at the Safer, Faster, Better. So this document was produced over about 18 months, 2 years. It's essentially an augmentation of all of the evidence and top tips essentially around the whole urgent emergency care pathway. So it's actually a linear journey through the emergency care pathway from pre-hospital through the acute hospital and back out into the community, and it looks at all elements of urgent emergency care, including primary care, social care and community services. So the report was actually endorsed by quite a few arm's length bodies, royal colleges and other health associated organisations. So it's been quite widely circulated and people have generally signed up to say that this is what the kind of future of urgent emergency care. So what's it all about? Well, essentially it's designed to help frontline providers and commissioners deliver safer, faster, better care to patients. So it's a series of top tips and evidence that has been tried and tested across England, and it's essentially design principles for good practice in urgent emergency care. It's really important to remember that it's not a mandatory set of rules or instructions, and it shouldn't be used as a checklist. So the last thing we want to see is sort of sequence and things like that being produced around the evidence base within Safer, Faster, Better. So it's a guide that argues for collaboration and consistency. The whole aim of it is to reduce variation, standardise practice in the delivery of care around what is doable within urgent emergency care. So we're really conscious that implementation of all of the stuff within the document there's so much stuff within it that you can't start at the start and go through to the end and implement absolutely everything. And actually it wouldn't be right to implement everything either, because we need to take account of the priorities for local systems and actually take into account the local context, what's happening, what are your priorities, what are your challenges, and actually what are the financial implications of doing this. Is it value for money, and is it the right thing to do for your population? So not everything within the document is right for every single area, but it's a good start. It's a good start to have a look at and have a think. Is this what we're doing? Because this is what good looks like. So in summary, it's a practical summary of good practice, and the really important thing is that everything within the document has been turned into reality somewhere in England. So when you look at some of the initiatives and some of the statements, we could point you to somewhere that has either done it or is doing it across the English NHS. So just thinking about the evidence base and what is good for urgent emergency care, and this is a bit of a revision essentially, and most people will know all of this. So the evidence says that if we prevent crowding in emergency departments, it reduces harm to patients, it improves patient experience, it saves lives, and it reduces length of stay. We know that getting patients to the right ward the first time reduces mortality, reduces harm, and also reduces length of stay. Patients who are seen quickly by a senior clinical decision maker have much better outcomes than those that are not, and they have a better experience, cost of care reduced, and length of stay is reduced. So you can see there's a general theme that when you invest up front in senior clinical decision making, that in the long run it will actually save money. So quite often we get the argument that it's expensive and it's not something that can be done. And there is a genuine argument around workforce, because quite more often than not we've got a real shortage of senior clinical decision makers. And if I just refer you to the Safer, Faster, Better document, it'll tell you what constitutes a senior clinical decision maker. So it's not just a consultant. We tend to say that anyone of ST3 level or above, from a medical perspective, nurses and therapists in their own sphere of practice that are senior and trained can also be senior clinical decision makers. And of course, it's not just about acute hospitals. Senior clinical decision making needs to take place in primary care. It needs to take place around discharge, social care, and community services. So it runs throughout the whole pathway. And these principles apply not just to the acute services, as I say. So if we think of daily senior review of every patient in every bed, we know that that reduces length of stay and costs. So that would apply to community hospitals, and you could also apply it to virtual wards and things like that. So again, going back to the senior clinical decision maker, it doesn't always have to be a consultant. We also know that when we assertively manage vulnerable elderly patients, it produces much better outcomes. It reduces decompensation of, of these patients, and ultimately reduces institutionalisation rates, and you don't have as many delayed transfers or medically fit patients in your beds. Acute assessment units enhance safety, improve outcomes, and reduce length of stay. And a really important point, mental health liaison services are really cost effective and are an essential part of the pathway. There's lots of evidence around early upfront liaison mental health services, and this is not just for crisis management but also dementia and other mental health presentations. So if you need to prioritise something, so what are the big ticket items? We would say that you need to balance capacity and demand. You need to keep flow going across the whole system. So I really stress that this is not just about acute hospitals. Reduce variation, and when we talk about variation, I think we're quite good at looking at system variation and individual department and ward, but actually some of the real killers of flow is individual variation. So the variation between individual staff members and individual consultants. And we'll come on to that when we look at the emergency department and how we can try and reduce that as much as we can. And managing the interface and handovers is absolutely essential. So that's information flowing across the whole system, across organisations and across health and social care. So delivering safe and effective care can't be done by one person. It can't be done by one organisation, and there are really no boundaries to it. So there's no point in having absolute islands of improvement or areas of absolutely cracking practice when the rest of the pathway is lacking and falling apart. So islands of improvement are no good for every patient. It's only some patients get the benefit of that. So I've already said this, but I'm going to really sort of try and force it home, in the sense is, please don't be tempted to turn the guide into a checklist and start performance managing the delivery of it. It's a different approach. We want to use the guide to stimulate clinical discussions around what does good look like, and it's a bit of a compendium, a go-to guide to get the actions of what can we do and how can we try and build a social movement to get this guide and get this report from the paper into action and delivering it for patients. So again, everything that is in the guide has been turned into reality. The building blocks are there, but it must be implemented systematically without variation and along the entire pathway. As I said before, there's no good having just little components. So if we think about how we target improvement work along the urgent emergency care pathway, and if I pick on acute services for one bit, we tend to split that into 4 essential length of stay streams. So we've got our ambulatory stream, our short stay stream, our sick general, and our complex. If we just target one of those, we tend to see the other 3 starting to go off piste, and it really just doesn't work. So you need to target all of the areas at the same time. We really want to use the guide as a social movement and get people committed, a real burning platform around what good looks like for urgent emergency care to provide a truly world-class service. I think we're already well on the way to do that, although it doesn't feel like it at some times. But when you look across the rest of the developed world, we're pretty much miles ahead of most places in urgent emergency care in general. So just as around the evidence base, and again this will be a bit of revision, but it's important to remember that over 43% increase in mortality 10 days after admission through a crowded emergency department for patients that come through that department. And stays in an ED of between 4 and 8 hours actually add nearly 1.5 days to your admission, and over 12 hours nearly 2.5. And that just it sort of perpetuates this circle of absolute decline. So we keep patients longer because we haven't got the beds, because they stay longer, their length of stay increases, therefore they get admitted, we don't have the beds, and so it goes on and on. Just from a clinical perspective, 70% of antibiotics are delayed by over 4 hours when emergency departments are crowded. And if we think of the sepsis bundle and the importance of getting early antibiotics in patients who are septic, that actually costs lives. And we also know that patients discharged following treatment in a crowded ED have a much higher risk of death in the next 7 days than those that aren't. So why does it matter? Why does exit block actually matter? So if we think about it in terms of patients, it's quite easy to look at the statistics, but you know, over 500,000 patients are affected by this annually, and you know, that's just not good enough. And it's estimated that there are 13 avoidable deaths for every 50,000 patients that move through a crowded emergency department. So, you know, most of our departments within our 28 systems see more than 50,000 patients. So there are 13 people dying needlessly because of our crowding in EDs as they move through these departments, and we need to put a stop to that. We need to change that. And we would suggest that crowding in an ED needs to be viewed as a hospital-acquired condition. We wouldn't tolerate it for many other things, and we know that this is happening, and we know that this is harming patients on a daily basis, and we really need to step up and do something as a whole system to try and sort this out. So just moving on quickly to emergency departments and what the evidence says. So we know that emergency departments must be resourced to practice good emergency medicine and not just deal with the demand that we hope for. So we've been in systems whereby the contracting round has stated that there will be a 20% reduction in emergency admissions, and we just know that that's unrealistic and it's not going to happen. So we do need to resource our departments to deal with what we know the demand is, and that's not just averages, but actually based on the variation that we know comes through the department. So our demand within ED is pretty stable on the whole, and we can easily plan for that. We do know that the 4-hour standard is a really good proxy measure of crowding, so we might not like it, but actually it's good for patients. Time not only matters from an experience perspective, but for all the reasons that I've pointed out, it really, really matters from a safety perspective and reducing harm and deaths. It's really important that we've got command and control in our departments. Floor management is absolutely essential with a triumvirate of operational management, nurse management and medical management, and that includes things like board rounds, walk rounds, or whatever way you want to manage it. But there needs to be grip in the department. And that brings us on to some of the contentious issues that can be with triage. So we often will state that triage is not a useful process in many of the systems that we see. So we would suggest that where triage is used, it should be very brief, it should add value, and it should aim to prioritise care, give analgesia, first aid, and initiate key investigations. More often than not, triage is a process that is a queue for a queue. And if we're going to triage, we need to make it useful and make sure that we include all of those things in it. So rapid assessment and treatment, I've got a couple of slides on that, so I'm not going to dwell on it, but what I would say is there is no one way of doing it. There are many ways, and actually the principle needs to be early senior assessment. It doesn't have to be necessarily a rapid assessment and treatment process. If you've got another process in place that delivers the principles of early senior review, then we know that that works and that is better for patients. We also know that having a see and treat stream within minors or within ambulatory services works really well, and this can also work well for minor illness presentations or some of the primary care presentations that we know comes through our emergency departments. So early senior decision making saves lives and it costs less. We've already stated that. Staffing should be planned to meet the variation rather than the averages, and reducing the variation is absolutely essential to standardise all clinical processes. So implementing things like internal professional standards, some key performance indicators, measuring time series along the pathway and having stamps and having a process mapped out that where escalation occurs when certain things aren't done by a certain time. So if we know that we're getting senior decisions made at 3.5 hours, we know that we're on a road to nowhere and we're just going to fail. And we do need to have a joint plan with ambulance services to manage handover safely. We did go through a pretty fractious stage last winter, whereby we had lots of media attention and lots of difficult conversations between acute trust commissioners and ambulance services. We know this is going to happen, so let's plan for it and let's have a joint plan in place using both of our resources with ambulance services so that we manage a handover of patients safely. We do know that co-located urgent care centres or minor injuries units or walk-in centres can be considered and do work, but there must be joint governance in place. So if you place, in general, there are exceptions to this rule, but very, very few. If you place an urgent care centre or a walk-in centre 7 miles away from your emergency department, it will not affect the attendances to the ED. So it could be absolutely right that that's what you want to do, but actually if the stated aim is to bolster primary care, then that's fine. But actually if your aim is to reduce attendances at your ED, the urgent care centre, WIC, or whatever the nomenclature may be, needs to be co-located, and there should be a single front door. There should be a seamless process that patients can move through that don't know the difference. Streaming is absolutely essential and promotes higher quality care. So we know that when we separate patients into minors, majors, resus, children's, we base it all around similar processes. it's really beneficial, and it helps with workforce, and you can configure your workforce to independently see patients that fit within their area of competency. So there should be something in place for high volume pathways. So where we know we've got high volume pathways like pediatrics, gynae, frailty, or some internal medicine, we should have fast track processes and direct referrals in place. So there have been some studies done whereby we know senior nurses within ED, qualified emergency department nurses, make the right decision, know when a patient needs admitted, and there is absolutely no reason why they shouldn't be able to refer directly from assessment to specialties when they know the specialty. The same with in times of surge, we could consider using things like our paediatric assessment units to clear the department for paediatrics and just call in some mutual aid from the rest of the organisation. So there should also be appropriate workforce to receive the demand if GP referrals are routed via ED. I don't have a personal preference around whether GP referrals should go direct to an assessment unit or direct to ED. I know that many people do. In saying that, we do know that assessment units do help and are better for patients and are safer. But where some departments do have GP referrals coming through them, then the appropriate workforce should be in place to receive those. So the teams that have accepted those patients should be seeing those patients in a timely manner. And actually the workforce around the ancillary staff, the support staff, diagnostics, etc., all need to take into account that the GP referrals are coming through that. And we need really good leadership. So that goes back to control. We've talked about internal professional standards. They're absolutely essential. What do I expect when I come to work today? How do things work in this place? When this happens, what do I do? It needs to be really simple, a set of really simple rules, 1 page, 2 pages maximum, to say, when I come to work today, this is how I do things in this trust. And just lastly, from this perspective, escalation procedures are absolutely essential. Clear triggers, meaningful actions, and actually making decisions. So Ipswich have got a really good escalation process trigger tool that they're more than happy to share with people, and we are planning to run a sort of a show and tell type event at Ipswich, which you will all be invited to in the next month or two, in the next couple of months. So, delivering added value, what does that mean? How do we do it? So we know internal professional standards are essential, simple rules are important. Standardized documentation helps, so single clocking, so that we're not moving and repeating ourselves and asking the patient the same question 3, 4, 5 times. Timeliness of assessments, decisions and treatments are absolutely crucial, and the timeliness of diagnostics and ensuring that we've got the capacity to deliver diagnostics within a 20-30 minute maximum period from request to report is essential to move the patient through the urgent emergency care pathways. There needs to be clear definition of responsibilities with delineation of roles, a senior clinical team, a managerial team and support services wrapped around to deliver the care that is needed within emergency departments. We also need to have if we want KPIs, but we prefer to call them measurements from improvement in place. So if we change the pathway, we are really aware that we're helping or hindering, and actually we need to make sure that we're measuring things as we go along. So metrics that we need to consider are outcome metrics, process metrics and balancing metrics. So if we do something, what are the potential unintended consequences? And let's measure them to make sure that we're not making things worse. Make this visible and share it. You can start to create a real buzz and a real burning platform. And it's about improvement, design and peer review. So this is just an example of some of the data that you receive from the ECIP data request. So this looks at the journeys of non-admitted patients and admitted patients through an emergency department. And this is quite typical of many emergency departments that are crowded. So if we look at the time in the department for attendances of the non-admitted patients, which is the top graphic, it's in 15-minute time bands along in 15 minutes along the bottom, and we've got the patients, and we can see that the majority of patients are being discharged in a pretty standard linear type manner. So, you know, we've got a small amount of patients being discharged at 15, 30 and 45 minutes, which we would expect, and after an hour it starts to build and build and build right up to the 240 minutes. What we would prefer to see is more of a dome-shaped graph here, where we've got the build happening around 90 to 135 minutes and tailing off back down to the 4 hours. So this demonstrates that this is a really congested pathway, and the bottom one demonstrates it even more. So we've got a surge of admissions or discharges at 225 and 240 minutes, with a long tail right out to 600 minutes. So when you get the data, have a look at yours, and if it looks like this, you probably already know, but it's definitely a crowded emergency department generally when you see this type of thing. So I'm just going to come on to some tactics and tips for helping with crowded EDs. So the next couple of slides have been taken from Mairead McCormick and Dan Harris at Barking, Havering and Redbridge Trust, and they hosted a day around flow a couple of months ago, which has gone down really, really well. And actually they've taken what was seen as an intractable problem in an ED through to actually delivering performance and delivering safe care on a pretty consistent basis now. So the next few slides, as I say, I can't take any credit for, but these are some of the things that they've enlisted to help them with the crowding in ED. So they use a process of reverse triage, which is essentially the assessment of existing known patients, so patients that are already in the department. Can we make a decision and can we do something with them? We do this to actually facilitate access for the undifferentiated or the new unknown patients. The whole process was designed for disaster management, but it's very applicable to the modern emergency department in the UK. And they use a stepwise traffic light approach, which I'm happy to share with anyone if they want to email the email address that Emma will give you at the end of the presentation. We can share that with you. But it's about clear roles and responsibilities, and it applies to emergency departments and other receiving units like paediatric assessment units, gynae assessment units, MAUs, etc. So just coming on to rapid assessment and treatment. So we said before that the principle is early senior input and decision making for undifferentiated sick patients. So whether you have a rapid assessment and treatment process in place or not, as long as you are dealing with and addressing the senior input and decision making, then that I think that is good. So this is the process that many departments up and down the country have adapted, and it is a RAT model. So we know that when you implement rapid assessment and treatment models for patients, that it improves patient safety, improves clinical outcomes, it massively improves flow within the department, and actually it's better for staff and the ED environment in general. So how does it do this? Well, it actually reduces unnecessary tests. So I know Nottingham have done some work looking at their recipe cards and early senior assessment by senior nurses, and they had a massive reduction in the tests that were ordered from ED. Subsequently, subsequent junior medical assessment is directed by the early senior review, so it's really good for junior training. Junior staff quite enjoy it. We do often get the argument that it doesn't help with training, etc., etc. But when we've spoken to junior staff who are involved in processes of rapid assessment and treatment, they do really enjoy it because they learn a lot, and they get to see what should be happening. Patients for admission are identified much earlier, so therefore we get some flow through the department, and the risk associated with patients awaiting senior review is reduced. So quite often we can refer early, senior clinician gains control, they have an oversight of the department, they know what activities there, they know what acuities there, and they can escalate very quickly with knowing exactly what's in the department. Most importantly, time-critical treatments and investigations are initiated early. So things like antibiotics, analgesia, other investigations are initiated much earlier than if patients bounce through a process of sequential reviews by junior staff and end up getting reviewed by a senior, and with the diagnosis changed and a whole raft of tests and investigations that they actually didn't need. And as I've said, junior doctors learn by example, they enjoy it, staff morale is much improved. But RAT is absolutely physically demanding, and we would suggest that if you do implement a rapid assessment process, that senior staff shouldn't really do it for more than 2.5 hours at a time. So there should be some rotation in place, because it's mentally and physically draining on the staff, and it's just not sustainable to be doing it for 12 hours in a row. And don't forget about the walk-ins. You know, a number of patients that are sick do come through the ambulatory route and not necessarily just through the major side. So have real flexibility for streaming within any system that you implement, so that we can move patients across and around it. And constructively challenge early decisions as the situation evolves. So it's not just about making a decision and sticking with it, but you know, it's an organic process. And actually juniors need supervised access to the process because it's good for them to learn. The aims of it is that it's a structured process. It clearly defines the roles. We need this rota, as I said, so that we can rotate staff and achieve the skill mix and the skills to run with the RAT process with some real defined outcomes. So a lot of the departments that have implemented have seen significant increased patient satisfaction, staff satisfaction, better flow through the department, and ultimately better outcomes. So the aim is it's consistent quality, timely management, and the safe treatment of patients. And that's the end of the presentation. So I did want to go through quickly so that we could have as many questions and debate as we can. So Diane Fuller from the Emergency Care and Intensive Support team is joining us on the call to help me answer questions. And if we don't know the answer, which we may not, we will commit to come back to you within the next 24 hours with an answer via email. Over to Emma, I think.
Yep, thank you very much, Stephen. So if there's anybody on the line at the moment who would like to pose a question to Stephen or Diane about what they've just heard and seen, if you could click on the raise your hand button on to your right. Alternatively, there is a box where you can type your question, and one of the team here can read that out for you to Stephen and Diane. I'll just pause for a moment to give people some time to do that. Okay, Stephen, it appears that you may have stunned people into silence, which is great. If there are no questions from those that are dialed in, then what I will ask is that if there are any questions that come to you when we've dialed off this, then please feel free to send those questions through to the ECIP info box. That's ECIPinfo, ECIPinfo @nhselect.org.uk. That's nhselect.org.uk. And then we will make sure that those are forwarded on to Stephen and Diane for you. So I think from my host, I'm getting the message that there are no questions that have been asked. And if there is nothing more from Stephen or Diane that they wish to add?
I haven't got anything, no.
I haven't got anything to add, thanks.
Okay, then thank you both. It just remains for me to say thank you very much to everybody for taking the time to dial in today, and to thank you to Stephen and Diane for taking their time out to join us as well. A quick reminder that...
Sorry, Emma, we've got Bev Wills wanting to ask a question. I'll just unmute Bev.
Oh, thank you very much.
Hello, this is Toby Slade. I'm one of the A&E consultants down in Truro in Cornwall. I just wondered, Steve, if you're looking at the escalation procedures that I saw up on the wall, on your slide, talking about surge escalation, which is sort of flow into ED. Obviously, ED are responsible to try and escalate that. Do you have a similar process for when there's a problem of flow out of ED, an escalation policy that involves the trust in terms of resolving exit?
Hi, Toby. Yes, we do. And I think you were instrumental in some of the development of it with Adam Brooks, but we use a full capacity protocol, and I know BHRT use that very well, actually, and there are a number of hospitals now up and down the country that have adopted it, so we could get a couple of those examples and send them to you if that would be useful.
Yeah, I think that'd be really useful for us. Thank you.
BHRT have agreed that the presentation from their recent Flow conference can be added onto our website, and they've got a specific piece within that on how they've implemented the full capacity protocol.
Thank you.
Thank you for that. Did we have any more questions from the floor at all, please?
I don't have anybody raising hands at the moment, no, Emma.
Okay. So in that case, once again, I'll say thank you very much to Stephen and Diane. Thank you for joining us. Any more questions, please send them through to the email inbox. And just as a quick reminder, we have recorded this particular webinar, and that will be available on our website as soon as possible, as will the remaining 6 webinars when they have been recorded and delivered. So goodbye from all of us, and thank you ever so much to you all for joining.